Hello everyone. Today we'll be talking about beta-lactam antibiotics. So beta-lactam antibiotics, these are a group of antibiotics that contain the beta-lactam ring in their molecular structure. And these include penicillins, carbapenems, monobactams, and cephalosporins. So mechanism of action of beta-lactam antibiotics. So they inhibit cell wall synthesis by blocking peptidoglycan cross-linking beta-lactam, which mimics the DALA structure of the bacterial peptidoglycan residue. So how it works is beta-lactam irreversibly binds to penicillin-binding proteins, which is PBPs, which act as transpeptidases. That leads to stalled cross-linking of peptidoglycan in cell wall. Beta-lactam cannot be cleaved. Inability to synthesize new cell wall during replication will lead to bacterial death. So basically, beta-lactam antibiotics have a bactericidal effect, which is they lead to bacterial death. Then the beta-lactam antibiotics, they activate autolytic enzymes. They have the ability to penetrate the CNS only when the meninges are inflamed. Exceptions include ceftriaxone and aztreonam, which always have good CNS penetration and not only when meninges are inflamed. The route of elimination is primarily renal via tubular secretion. Exceptions include biliary secretion. Biliary elimination is of nephilin, and both renal and biliary elimination is other anti-staphylococcal penicillins such as oxacillin, dicloxacillin, ceftriaxone. So what are the general adverse effects? So we have the Jorisch-Herxheimer reaction, which is seen in treatment of syphilis, hypersensitivity reactions. So beta-lactamase inhibitors, which are our beta-lactamases, so they're usually produced by gram-negative and anaerobic organisms. So this can split the beta-lactam ring and render certain beta-lactam antibiotics ineffective. So remember our class of drugs is beta-lactamase inhibitors, right? So we have got some pathogens that are able to produce beta-lactamase, okay? So which pathogens produce the gram-negative and anaerobic organisms? So they're able to split the beta-lactam ring, due to which beta-lactam antibiotics are ineffective. So beta-lactamase inhibitors, they prevent the destruction of beta-lactam antibiotics by beta-lactamase and increase the spectrum of the antibiotic activity. So this can be co-administered with beta-lactamase sensitive penicillins in order to treat beta-lactamase producing organisms. So examples include clavulanate, which is combined with amoxicillin, F-bactam, which is combined with ceftazidime, sulbactam, which is combined with ampicillin, and tazobactam, which is combined with piperacillin. So let's talk about some natural penicillin. So these are the prototype beta-lactam antibiotics. And the examples include penicillin G, which we commonly refer to as benzyl penicillin. IV, we've got crystalline penicillin G. IM protein penicillin G, benzathine penicillin. Then oral, we've got penicillin V, which is our phenoxymethyl penicillin. Clinical use of beta-lactamase inhibitors include gram-positive aerobes, especially Streptococcus pyogenes, Streptococcus pneumoniae, gram-negative cocci, especially Neisseria meningitidis, spirochetes, especially Treponema pallidum, and branching gram-positive anaerobes, especially actinomyces. So the adverse effects include hypersensitivity reaction, hemolytic anemia positive direct Coombs test, drug-induced interstitial nephritis, seizures. So what is the mechanism of resistance to beta-lactam inhibitors? We have got our cleavage of the beta-lactam ring by beta-lactamases, which is our penicillinases. And if these are PBP mutation, then our drugs are not going to act on this. I've got penicillinase-resistant penicillins, examples oral or IV. So those are nephilin, dicloxacillin, oxacillin, fluoxacillin, methicillin. So these ones are penicillinase-resistant penicillins, okay? So penicillinase is not going to act on these. Special characteristics include intrinsically beta-lactamate resistant through the addition of a bulky side chain, e.g. of isoxazolil, which prevents bacterial beta-lactamase from hydrolyzing the beta-lactam ring. So clinical use, the narrow spectrum, gram-positive aerobes, especially Staphylococcus aureus, non-MRSA. Remember what we said, MRSA is methicillin-resistant. And here we talked about methicillin. So methicillin does not work against MRSA. Penicillinase-resistant penicillins are not effective against Streptococcus viridans, Enterococci, or Listeria species. So adverse effects include interstitial nephritis, especially it's associated with methicillin use. Then we also have hypersensitivity reactions. So what's the mechanism of resistance? So there's alteration of PBP binding site which leads to a reduced affinity. Pathogen is not bound or inactivated by beta-lactam. Because there's an unaltered PBP target site is one of the main virulence factors of MRSA. So introduce nephicillin for Staphylococcus aureus. And let's talk about aminopenicillins, which is penicillinase-sensitive penicillins. So examples include oral or IV amoxicillin, which is combined with clavulanate, IV or IM ampicillin with or without sulbactam. Special characteristics. So the molecular structure is similar to penicillin and therefore susceptible to degradation by beta-lactamase. So they are beta-lactam sensitive. Oral bioavailability of amoxicillin is greater than that of ampicillin. So clinical use. So they have a broader spectrum of activity than penicillin. So we refer to them as extended spectrum penicillin. So they work against gram-positive aerobes, gram-negative rods. However, it's not effective against Enterobacter species. And it's most effective against Helicobacter pylori, Haemophilus influenza, Escherichia coli, Listeria monocytogenes, Proteus mirabilis, Salmonella, Shigella, Enterococci, and spirochetes. Adverse effects include diarrhea, pseudomembranous colitis, hypersensitivity reactions, drug-induced rash, and possibly acute interstitial nephritis. Non-mechanism of resistance is cleavage of the beta-lactam ring by penicillinases. Then we have got our anti-pseudomonal penicillins, which include IV piperacillin, IV meslocillin, IV tercacillin, IV carbapenems. Clinical use includes expanded spectrum, but penicillin is sensitive. So they mainly work on gram-negative rods, especially Pseudomonas. They're also effective against anaerobes such as Bacteriaceae fragilis. Gram-positive aerobes are not effective against Streptococcus viridans. Adverse effects, hypersensitivity reaction. Carbapenems. So examples include IV imipenem, which is combined with cilastatin, IV meropenem, IV ertapenem, and IV doropenem. So imipenem is always given with cilastatin, which inhibits human dehydropeptidase 1, which is a renal tubular enzyme that breaks down imipenem. Meropenem is stable to dehydropeptidase, so with this one you do not need to combine cilastatin. Clinical use. So one thing you need to know is carbapenems, they're last resort drugs, okay? They are used only in life-threatening infections or after other antibiotics have failed because of the significant adverse effects. Broad-spectrum antibiotics with intrinsic beta-lactam is resistant, gram-positive cocci except for MRSA and Enterococcus faecalis, which are intrinsically resistant. Gram-negative rods including Pseudomonas aeruginosa, except ertapenem, which has limited activity against Pseudomonas and anaerobes. Adverse effects include secondary fungal infection, CNS toxicity, which can lead to a lowered seizure threshold at high serum concentrations. Highest risk is imipenem and lowest risk is meropenem. GI upset, rash, thrombophlebitis. So mechanism of resistance is they can be inactivated by carbapenems, which is a type of beta-lactamase. It's produced by carbapenems producing Enterobacteriaceae, such as E. coli, Klebsiella pneumoniae, and K. aerogens. So that's all about beta-lactam antibiotics. Thank you.